2-minute video that we'd like to show to you about the previous edition in Bengaluru, the 8th edition Healthcare Summit, that shows you the highlights of the event, what were the discussions, what was the feedback from the various delegates, and so on and so forth. Can we please roll the video of the 8th edition highlights?
It was a fantastic event. We are dealing with the healthcare industry, and it was so good to meet all the potential clients, and we got a lot of hot leads from the event. Thank you so much.
Yeah, on that.
This is a wonderful opportunity for us to make a good networking, to know about the solutions and know about the market, and to further take it forward for any kind of business.
Everybody's interested in healthcare these days, so it was good to see a good participative audience, even from academic.
The highlight of the conference was really the enthusiasm that healthcare leaders, the startup companies, the various vendors have expressed in improving patient outcomes. That definitely was, I think, a common theme throughout the topics, and it was very rewarding to hear that.
Those were the highlights of the previous edition, and the 9th edition promises to offer all of this and hopefully a little bit more as well as we keep improving. So we know that healthcare is an important discussion, but from the government's perspective, what are the key themes on the government's renewed focus towards healthcare and improving the healthcare facilities in our country? To answer this very important question, I'm very pleased to invite our keynote speaker this morning, who is from the Vice Chairman's Office of Niti Aayog. Please help me welcome for our keynote presentation, Mrs. Urvashi Prasad. I would request you all to please help me welcome Mrs. Urvashi Prasad for the keynote presentation this morning. Ma'am, the stage is yours.
Thank you very much, and it's a pleasure to be here. I've been asked to outline some of the priorities of the government and the policy priorities when it comes to healthcare. And I think, it's very important to appreciate the changes that have been happening in our healthcare system over the last several years. One is that there has been a shift from just thinking about curative hospital-based care to preventive and public health care. So that has been a big shift that we have been seeing. And especially after the pandemic, there is a lot more focus on promotive and preventive health, wellness. A lot of people have become more conscious about their health and well-being. So I think that is one very important shift that we are seeing even in the policy space. That there is now more focus not just on building more hospitals or bringing in more insurance schemes, but also focusing on preventive aspects. And under Ayushman Bharat, the government has set up health and wellness centers. And basically the idea of these health and wellness centers is to provide comprehensive primary health care, which means that it's not just about reproductive maternal child health, but also screening for non-communicable diseases, also promotion of good health, right? Whether it is through yoga, whether it is through other means of promoting well-being. So there's this whole shift, I think, that is very, very important, to recognize and is being increasingly acknowledged in the policy space. The other, sort of big focus for the government and policymakers is that, we are a very diverse country. We don't need to provide health services in only large urban centers. We have to reach every part of the country, right? The rural, the remote areas, the tribal areas. So the government is trying to, including through public-private partnership, reach out to people in all these areas, because there is a lot of gaps in terms of healthcare provision in many of these areas. There's a lot of inequities, not just between states, but within a state, between districts. There's a lot of difference in terms of provision of healthcare services, quality of healthcare services. So this is a big focus that, we need to plug these gaps and we need to address these inequities. The other big aspect is how do we use technology? Because, technology, digitization, these have all, become really important drivers, enablers for the healthcare system, especially after COVID. During COVID, we saw that there was an acceleration in the adoption of technology, telemedicine. So, we need to make sure that there is, no digital divide. We also have the problem of digital divide when it comes to technology. So we don't want that, we have all these fancy technologies and artificial intelligence and, Internet of Things and whatnot, but we cannot actually make sure that these are reaching, people in rural and remote areas. So again, we need to make sure that technology is reaching all parts of the country, but it can certainly play a very big role in improving the efficiency of the health system. If we look at something like artificial intelligence, for instance, if today a doctor has to go through multiple manual records, if we use artificial intelligence, then we can actually, help the doctor to arrive at a quicker diagnosis, right? So it doesn't substitute the doctor, but it certainly helps and enables, their work and improves the efficiency. So I think, that is something that we're looking to do more of in the health system, but addressing and being cognizant of the digital divide, that exists. Another very important area, from the government's point of view is, drugs and medical devices. And we saw that a lot of innovation happened during the pandemic. We were able to come up with these vaccines. There was a lot of collaboration that happened between the public sector and the private sector. But we need to continue this, because there are many other diseases for which we don't even have vaccines. For instance, if we look at tuberculosis, we still don't have a vaccine for adult tuberculosis. So of course, these are not just India's problems. These are global problems, and they do require collaboration, even between countries. But certainly, our private sector also needs to step up investment in research. Definitely the public sector needs to, spend more on research. But if you look at the split, of the research funding, most of the research funding in our country comes from the public sector. There's very little that comes from the private sector. So, yes, while we need to increase, government spend on R&D, we also need the private sector to step in. Especially when it comes to rare diseases, neglected diseases, diseases which have troubled us for many, many years, like, the example of tuberculosis that I mentioned. But increasingly now, we also need, vaccines, we need drugs for non-communicable diseases, because as many of you would be aware, the burden of non-communicable diseases in our country is really going up. It's not just communicable diseases that we're dealing with. So I think that is another very, very important dimension that the government is looking to tackle. The next, piece that I would really highlight is the human resources for the health sector. Of course, we need more doctors, we need more specialists, there's no doubt. And the government has been trying to really invest in terms of medical colleges, nursing colleges. But we also need other cadres of health professionals. We need public health professionals, for instance. That is something which has been sorely lacking in our system. And that comes back to the first point I made, that because we are a very hospital-based health system, a very cure-focused health system, we've always limited our discourse to, doctors, specialists, but we haven't spoken about other cadres of health professionals as much. So that is something we're trying to do now, that public health professionals, in other countries you have cadres like nurse practitioners. We need to help build these cadres in our country as well. Community medicine practitioners, family medicine practitioners, all of these, sort of cadres have sort of either not existed or somewhere they have disappeared in the discourse. So we're trying to, bring back a focus on all of these. And we're also trying to reform the whole system of medical and nursing, education in the country, because there's a lot of reforms that are needed to improve the quality of the education. And to improve the quality of the graduates that come out of our medical and nursing colleges. So that is another very, very big dimension that we are addressing. And finally, I would just highlight that the country is going through a demographic transition. While we always think of India as a country of young people, actually the population of senior citizens now is really increasing because the fertility rates have stabilized in the country to a great extent. And in many states in India, especially the southern states, the population of senior citizens is already very, very high. And the same thing is going to happen across the other states as this demographic transition takes place. So we no longer need to think of our health system only in terms of catering to young people. Of course, that is still important and that will always remain important. But we also need to think about how do we provide healthcare for the elderly, for senior citizens. How do we put in place health services which cater adequately to them? So that is something which is also, an emerging policy priority. So these are just some of the areas I wanted to, highlight in terms of, macro level issues for the health system as well as for the government. And I'm sure, you will be talking about many of these aspects in the sessions later on in the day. Thank you very much.
Were very interesting points, especially when you mentioned the need to focus from moving from a cure-based system to a preventive care system, and all of the various initiatives that you are taking to make this happen. Another eye-opening point was the demographic shift that you pointed out. I think that's something that many of us overlook so easily. It's all over the news. India is a young country, which is true, but at the same time, we also have an aging population. and we need to ensure that we have quality healthcare facilities for that aging population. I thought that was a very good point, and thank you very much for sharing your knowledge and experience with us, ma'am. And, and on this point of quality healthcare facilities, how exactly do we go about making this a reality? How do we provide those quality healthcare facilities? It so happens that our next keynote presentation is going to discuss just this topic, quality healthcare. And please help me welcome on stage our next keynote speaker, the Group Medical Director of Sarvodaya Hospital and Research Center, Dr. V.R. Gupta, for the next keynote presentation.
So, good morning, everyone. Thanks, Mrs. Urvashi, just setting the stage for the day. And I have been given this topic, quality healthcare in India. I'm Dr. V.R. Gupta, working as a Group Medical Director at Sarvodaya Hospital, NCR, Faridabad. Before that, I was working as a Medical Director in Medanta Medicity and Escort Heart Institute, New Delhi. My experience in healthcare is around now 25 years. And for the people, I have just taken the quality healthcare, that healthcare in India is interesting. It's because India is having largest and fastest growing industry, serving the ever-growing population, and it contributes to GDP growth also. And according to report, the Indian healthcare industry, which was around only 17.62 trillions in 2020, it's growing at the rate of around 30% yearly, and it's going to touch around more than 81 trillion by end of 2026. And as Madam Urvashi has already told, digitalization, the effect of rapid digitalization of healthcare, which we started our journey in India at the time of COVID-19, how things started, like even when we were getting the reports, we were excited, all help of digital media. After that, you know the story, how vaccination was done. As soon as vaccination is done, we used to get report on our WhatsApp. So the digitalization in India has made a very good impact on healthcare, and of course, that's a game changer. So many things will be evolved after that. But Indian healthcare is facing a lot of challenges. So what are these challenges? Which you already know, just try to take few important things. Of course, inadequate infrastructure, whether it is public or whether it is healthcare by private healthcare system. So private healthcare system is very good quality, but it may not be affordable to all. And why? Because lack of income and lack of basic health insurance facility, because till now only very few people in the country, they have got the basic insurance. On the other hand, public healthcare system also lacks some infrastructure issues or digital-led solutions. Rural government hospitals are also undeserved primarily due to insufficient amenities such as building, equipment, infrastructure, etc. Of course, shortage of health personals. Maybe I would like to thank even Government of India, National Medical Council. They are trying to increase the seats of postgraduate doctors in India. I was with the NMC person last week, so I was quite surprised that their aim in the next 3 to 4 years, they are trying to equal the number of graduate as well as postgraduate seats. Still now it's around 1.5. Earlier it was very less. They were about less than 30-40% postgraduate seats were there as compared to total MBBS seats. But now, National Medical Council with help of Health Ministry, they are trying to do that so that more specialists are produced. Similarly, not only doctors, the nursing manpower, the front office manpower, and again, the last, maybe in this year only, maybe around 150 more nursing colleges has been promised by Health Ministry. Then lack of affordability, expensive healthcare treatment. So beside accessibility, another connected and underlying challenge in healthcare sector is affordability. Since they are uninsured, so naturally significant people, they have to pay out of pocket expenses, and that amount is also very high in Indian healthcare industry, because the people who are already insured has got very minimal population. Then we have got a very less emphasis on preventive care. Today now it's a period of preventive care, because if we don't focus now, how we will do in the future, and because of lifestyle diseases, whether it's diabetes, whether it is hypertension, etc. I am sure with help of tools like artificial intelligence, where we can do some predictive analysis. There are a lot of genetic tests which have been started. For example, if at the age of 20 or 30, somebody undergoes all these tests, then they can find out that if there is a family history of diabetes or CAD, how many chances are there at the age of 50 or 60 that that particular person will develop those diseases. But again, it's a very important aspect to take focus, so that naturally prevention is better than cure. And we are happy to know that every private hospital and other good hospital, now they are trying to have good wellness center also, so that it can be on the preventive care. Of course, there is a disparity in rural and urban healthcare system, because 75% of good healthcare infrastructure, they are available in urban areas, where only 27% of population resides. So this figure I have taken just so that we can make an idea that how this rural versus urban systems are lacking as far as infrastructure and disparity is there. And I have already told you high out-of-pocket expenses, how they can be cured if people have taken insurance schemes. So how we can have quality healthcare, how we can have strategies to improve the healthcare sector. So of course there will be a very, very big role of technologies, whether it is telemedicine, whether it is artificial intelligence. In fact, we had one session yesterday in the same hotel on the ground floor, whole of the day, that was on digital technologies. And things have changed very fast, whether it is data, whether it is data analytics, whether it is your e-ICUs, where like Tier 2 and Tier 3 cities in India, they don't have very good critical care. So the cities from metropolis cities, they are able to control those ICU where expert doctors, they provide the consultation, and naturally patients are benefited because of the use of this all digital technologies. And telemedicine, that's self-explanatory. India is already going towards that. Then healthcare financing. Healthcare financing also focus on generation, allocation and uses of financial resources in healthcare system. So government is trying to do that, some balance, so that the financing of healthcare systems can be done, maybe whether it is a startup or some other sort of businesses. And government initiatives, of course, Madam Urvashi has already told, and we are happy to know that our even Ayushman Bharat Yojana, that's also a very, very big project. How many people have been enrolled? Minimum like 5 lakhs benefit up to those are given. So way forward, Government of India is implementing extensive structural and long-term reforms to boost the healthcare sector, so that the healthcare GDP, it can be increased, and there can be foreign direct investment on healthcare, so that the infrastructure of healthcare can be better. And medical facility, they are also reaching to Tier 2 and Tier 3 cities, so that even a person or a family in rural healthcare, they have also accessible to healthcare. Then there are universal health coverage program with this Ayushman Bharat Pradhan Mantri Jan Yojana, which have trying to make a very good impact on the people, and so many hospitals have already enrolled for that, and so many families have got benefit from these schemes, so that healthcare is accessible to all. Then another venture, public-private partnership, so many things, not only in hospital, but diagnostic centers, education also, so many good institutions, they have started working on public-private partnership, so that it can benefit the quality in healthcare, whether it is accessibility, whether it is output of the healthcare. The CEO of NABH, Sir Dr. Kochar, is already here, and I am also associated with NABH. Just to tell you that one part is government structure, private structure, quality healthcare structure, but how quality in healthcare is implementing very good system in India. And I want to thank NABH that what we have seen journey in last 16 to 17 years. When the first edition of NABH came, it was just basic, and now already 5th edition standards are there, and 6th edition will be coming next year. The level of quality, the bar of the quality, it has increased not only to bigger hospital, it has gone to smaller hospital, it has gone to allopathic center, it has gone to diagnostic center, it has gone to various dental center, eye center, Ayushman center, you name any center where you want to start quality work, NABH has got a standard for it. And I have seen the journey myself, what impact it has created. Earlier, doctors were considered good, and patient used to say, Doctor Sahab, aap Bhagwan hai, jo aapne karna hai, kar lijiye. But now, common Indian literate person, they have got a choices. They have got a right to select their doctor. They have got a right to choose their hospital. They have a right to refuse treatment. They have right to seek an alternative opinion by Dr. X or by Dr. Y or Dr. Z. So all these parameters, and it has also helped to raise the level of quality in hospitals, simply starting from consent taking procedure to clinical outcomes. And especially the 5th edition of NABH, lot of clinical things have come, clinical audits, clinical pathways, which were earlier not part of practice in government and private hospital. And the root cause of all these problems was there, because when we are doing MBBS or MD, we are not taught anything. And now, again, thanks to National Medical Council, now they are putting all this into syllabuses. Quality will also be in syllabus of MBBS, IT will also be part of syllabus. Even medical legal cases, poor doctor does not know after doing post-graduation or super specialization, when he comes to a big city for practice, he does not know what is medical legal case, how to handle medical legal case, what is the importance of documentation, and whether it is medical legal case, whether it is court case, whether it is any social media against doctors, there are only two issues. If communication with patient is good, and whatever we communicate, if it is documented, naturally a lot of problems will be sorted out. And I have seen in my career of around 25 years in healthcare, working with prestigious institution, and this is the level of quality, this is the bar of quality which is trying to improve. So that's all from my side. I try to tell you in 10 minutes our problems, our strategies, what government is trying to do, what private sector is trying to do, and with help of quality initiatives by NABH and other parameters, we can collaborate each other, we can work together, and with help of the subsequent session, whether it is on emerging technologies, emerging infrastructure, and other things, I am sure that healthcare industry, which is going very fine, which will be better, and you see the impact. A lot of patients are coming out from other countries to get treatment in India. And that's a testimonial that our healthcare, our doctors, our paramedical staffs, already they are very good, but now they are going in a systemic way. Even medical value travel facilitator program by NABH, that is also helping. You don't know, there are certain gray areas with facilitators and other people who are in international marketing, but we are trying to do that. For example, infertility, that's another area where a lot of hanky-panky things occur, but government is trying to come with the bill so that all these things become a process, a system, and if we work towards structure, process, and system and outcome-based, naturally the quality in healthcare will progress. That's all from my side. Thank you very much.
Yes, thank you very much, Dr. V.R. Gupta, for many interesting things in your presentation. But of course, one thing that caught our attention was yesterday's session on how there was so much of focus on digital technologies, and so many things are changing so fast to make our healthcare infrastructure accessible to everyone. And especially in the other cities, the tier 2 cities and smaller cities of the country. So there's so many things that are happening. And in fact, to continue that discussion on what is being done from an engineering design perspective to make hospital infrastructure and healthcare facilities more accessible, our next keynote presentation is going to take a closer look at futuristic approach in an engineering design for our healthcare facilities. And for the next keynote presentation, I'd like to invite on stage Mr. Hari Prasad Nair, the Director of STAT Consultancy Private Limited, of course, one of our partners for this initiative. Please welcome on stage Mr. Hari Prasad Nair.
Good morning to all. With the 10 minutes, I was little struggling to find the right topic to be taken. So, pandemic has taught us it has to be we did a lot of modifications in hospitals to accommodate negative pressure rooms or take the COVID patients. A lot of MBP modifications happened, brought in a lot of trouble to the hospital. So, how do you do futuristic changes? How do you accommodate this? Looking at the future, how do you take the MEP design while designing a hospital? This is just a small, 4 or 5 slides which I would like to take it. So, what generally is you design a hospital, you make the space for that much, and you don't look at what extra. This extra thing is because of the cost. You think that if I need to put space for a chiller, or if I need to space increase the capacity of the electrical system or the UPS, then fine. Cost is the first criteria. But you never look at what is going to happen. Any hospital, for that matter, any hospital has grown only. I don't think any hospital which has performed well has only grown beyond your expectations at times, and beyond your thought process, because departments have become different, the concepts have become different, lot of things, lot of change. For example, when you were doing Linacs, the linear accelerators, earlier it's only 2 bunker, it was standard design. Now you have to look at how an MRI Linac has to be accommodated. Now you have to look at how a PET Linac, which is likely to come, I think only 2 installations in the US, so which is likely to come, how that has to be accommodated. So such things will come. So taking, how much you can take, you cannot take everything on that, but at least have something on your mind and do that, consider that in the design. Otherwise, the cost, the initial cost is there, but the modification cost is too much and it will have shutdowns. You have to avoid shutdowns to the extent possible to the existing facilities. So how do you do that? Yes, ma'am. So this is how it is. The available solutions, initially it's more. But as you go on, the available solutions are coming down. The available solutions is because you have done the construction without accommodating the changes. This is just a graph. The other graph I cannot show because most of us do this way only now. So this is key considerations while doing the flexibility when you are taking into consideration. What are the key considerations? What is that you have to look at is what I am trying to. So this is one point, modular surgical booms and then hybrid ORs. When I have an OT, for a cardiac OT, the pendant position is at some position. For an orthopedics OT, it is in a different position. Or for a neuro OT, is in a different position. So all these different positions, how do you accommodate? So then you have solutions to accommodate that. I don't think you have to do for the entire OT, at least 1 OT or 2 OT. I need to have some flexibility. So consider the pendants, the medical gas pendants in such a way that that is flexible for that particular theater, and the others can be fixed. At least 1 or 2 out of the whole. If you look at the flexibility or the modularity, that'll be good. That's what. So this is, just a photograph. Because now the surgical robots are coming. Surgical robots are also evolving. It is not that, no, it is fixed somewhere. It is also evolving. On the neuro procedures, a lot of things are coming in. So the other point is, how do you, redundancy in AHU. Redundancy in AHU, normally, we don't consider. Giving a space for one AHU itself is too difficult for the architect, negotiating with the architect. So redundancy is one which has to be. Redundancy is mandatory as per any code, international. We have not reached there, but we will reach there. We will reach there because the Indian standards also is more or less getting adapted to the international code. So today, redundancy is not there for the surgical room air handling units. That tomorrow, some of the places it is not done. I'm not generalizing the designs. I'm saying some of the places it's done, some of the places it's not done. So wherever it is not done, please consider redundancy in critical sites, like at least in the OR and then in the cath lab or in the MRI, where AHU can stop the MRI don't function or a LINAC don't function or the operating room don't function. Then medical gas system, pandemic has taught us medical gas system, how much oxygen consumption has increased. Your 2000 liter per minute is the general, your control panels you get. This has gone much beyond that, 5,000, 6,000 LPM and all it has happened. So how do you, consider, how much you can consider, or you have divide the whole thing into two or multiple control panels so that the futuristic thing. And when you're designing the air compressors, make sure that you have space for expansion. When you're considering the vacuum pumps, give space for expansion. Your demand calculations might be right, but for how much you can expand, how much you have to expand. So all that has to be taken into consideration. Emergency power. This is one typical example. Initially the patient room was done with a family waiting, and if one duct is done, the straight, the two lines which are shown as the cap duct work, and it is done initially. And tomorrow, if I want to convert that family room to a negative, these two rooms to a negative pressure room, in the family room I put an exhaust, remove the glass, put the, let the exhaust go out of that, then it becomes to negative pressure room. So such small strategies can help you achieve a lot without, major demolition, it's all planned for the future. So this is where this is again this is adaptable. This is plug and play. I can remove the bed panel and I can add one more, or I can increase bed capacities. You get such items. It's expensive initially. But at least for the future, not for every room in the hospital. At least for some. So this is generalizing. If you are not flexible, you're going to go, the cost is going to go up. If you're not flexible, later on the cost is going. Shutdown is a major challenge we face. Shutdown is the biggest challenge we face when we look at expansion. So when I do not have the right valve placed in the medical gas, I will not be able to expand the medical oxygen. So you should have the valves for expansion, where to expand, how to expand. All that has to be, some thought process has to go into, so that later on, when you want to expand, it will not happen. And sizing also. Don't size just for the sake of the present building. Make sure that whether it is horizontal or vertical, wherever the sizing, it has to take. So that's all. It was a very, given the time, I thought I'll have a very small topic which can fix in this. Anything? Thank you.
Thank you very much, Mr. Hari Prasad Nair. I think you mentioned actually several times in your presentation how shutdowns are such an important, such a major challenge, and how it is important to avoid shutdowns as much as possible. But of course, it is also important to keep in mind that new facilities and amenities are always coming through. And what are those new facilities, amenities, trends that are emerging in the healthcare space, and how are they being included in the healthcare design to avoid shutdowns and other challenges? This is actually a very important discussion, and we have a we have assembled a panel discussion to dissect this topic, understand what the emerging trends are, and what are the best ways to implement those trends in the hospital design and planning phase. So I'd like to welcome our panelists one by one on the stage, starting with Mrs. Brinda Sengupta, who's the Vice President of HKS in Singapore. I'd also like to welcome Mr. Nikhil Gupta, who's the Head of Marketing and Commercial Operations at Signify. Please help me welcome on stage Dr. Atal Mohan Kochar, who's the CEO of NABH. Also, Mr. Karan Thakur, who's the Vice President of Indraprastha Apollo Hospitals. Mr. Manu Malhotra, who's the Director of RSMS Architects, who will present an architect's perspective on the emerging trends in hospital planning. We also have Mrs. Preeti Venkatraman, who is the Business Practice Leader and Vice President of Canon Design. And our moderator for this discussion is Dr. Yash Pal, who is the Managing Director of Astron Hospital and Healthcare Consultants Private Limited. So Dr. Yashpal Bhatia, our moderator, who will present questions to our varied panelists over here, who will offer various perspectives from an architect's perspective, from a healthcare professional's perspective on what are the emerging trends in the hospital planning phase and how can we go about implementing those new trends, new and emerging trends. So,
couple of people get to join, I suppose.
Yes, couple of yet to join, but the stage is yours for the next 45 minutes or so.
Good morning, ladies and gentlemen, and welcome very, very eminent panelists that I'm humbled as well as honored to moderate this morning. You know, as the session has been suggested, we are talking about the infrastructural issues, infrastructure challenges in the new healthcare delivery system. All of us have witnessed last few years where in spite of talking about what we are trying to about the globalization, what we are trying about doing the best in the industry, what we are trying about the most modernization. But when it came to deliverance, there was a challenge. There was a global challenge, not that we were challenged in India. It was the whole system which was challenged. And I don't know whether we came out with flying colors or we didn't come out with the flying colors or what exactly it happened. But all of us, the community as a whole, suffered. The question came at that time, were we prepared? We were not. The question which is being asked even today, are we prepared? We don't know the answer. So these are the challenges which, you know, my most eminent panelists sitting on the table will probably have a lot of thoughts, a lot of experience on. You know, basically, our discussion is focused on the significance of integrating smart solutions to healthcare infrastructure to tackle these challenges. COVID is now a known challenge. What will be the next? We don't know. And are we really prepared for that? So ultimately, you know, with the improved healthcare outcomes, better patient care comfort, increased efficiency and team coordination, enhanced patient experiences, and more importantly, reducing the overall costs. We are actually fighting on that. On one hand, the overall paying capacity, that's a challenge. The healthcare system is more and more getting third-party payer dependent. And once that is happening, all the challenges of the costs are coming into place. As we run the hospitals, we do realize that the price challenges, the schedule of charges is something, which is competition based. The schedule of charges are being regulated by the third party payers. What we have to look at it, our own costs. And the costing of the hospital or the costing of the services is so much integrated into the hospital design, as all of us in this room, we do understand. And that's one of the challenges which is going to remain. Also, during these challenging times, what were the adverse impacts on the system? How we have overcome on that, and how we can make a future proofing on that, that's going to be the question. And accordingly, the resilient healthcare infrastructure. On one hand, we are there to provide for the requirements of the medical value to travel, as it is becoming very, very eminent. Some of the hospitals, as high as about 30% of their patient load is based on MVT, so where you are actually compared to the global situations. On the other hand, we are talking about EWS, Ayushman Bharat. On the other hand, we are supposed to be ready for any of the renewed pandemic that may come up again. So these are the places where we have to put the resilient situations. And those are the threats. These are the threats of the industry which we are working on. And while we are working on that, welcome Manu. Those are the threats on which we are working on, and I am sure that the future designs will be addressing to them in a really big way. Sustainability and resilience are the two new kind of mantras which are coming up along with the hospital design parameters, and today we are required to address to that. So more than any times, now it is more essential to predict and plan the future. Of course, we are not astrologers. Of course, we are not sitting over here as saying that I can write the Janam Patri of what is going to happen in the future of the infrastructure. We are not here for that. But there is enough scientific evidence which has brought us to a situation that we can think of the future. Logically, scientifically, architecturally, we can put across into that place. And the very, very eminent group of people sitting over here, they are experts in design. They have a lot of international exposure in what's happening across the globe. They are into process. They are into standardization. So with that, I think today's discussion, I'm expecting that we'll be able to have a lot of situations which we can discuss, the ordinary ones, the extraordinary ones, the unexpected ones, and the unanticipated ones. So with this, I'll start with my I shouldn't call it a question session, question answer session. It's because it's not a viva, or it is not something that we are conducting a kind of interview. We are just a discussion. And as we start with the panel discussion, the first I would like to start from the, of course, Mrs. Upasana Arora is not here, so I'll start from Mr. Karan Thakur. So, now that we have reached that stage, we have all the situations we have passed on. What is your evaluation on the hospital design on post-occupancy of all these situations?
So thank you for that question, and thank you for having me here. I think our initial remarks were really on point. As you said, during COVID, we were faced with a black swan event. We were prepared in bits and pieces, but not prepared for the uncertainty and just the numbers that we saw. I foresee climate change as being the next challenge that will come. It's the perpetual pandemic. We're already seeing that across the world, it impacting health institutions, hospitals, and people. So the climate crisis is a health crisis, and I think that needs to be now imbibed into design. In terms of your specific question on post-occupancy evaluation, even in the best of systems where administrators, planners, architects, leadership work together on hospital design, we see the end product that is given to stakeholders, and it's important to consider all stakeholders, patients, visitors, staff of all levels, whether it's doctors, nurses, even the security staff, there is a gap. It used to be a yawning gap, but now the gap has actually reduced. But that gap remains. And some of the times what we find, the initial planning, you may have planned for a 50, 100, 250, 1,000 bed project with different specialties that you were looking at. And during the gestation period, which in healthcare is quite long, by the time you commission, either the market has changed, the demand has changed, the socio-economic environment of where you set up the hospital has changed. And I think that nimbleness needs to be built into the design, and you need to have foresight that things may not actually work out once this hospital is commissioned, because we are planning from today and there's only so much horizon scanning you could do. But once you have occupied, I think it's very important for hospital leaders to work with their designers and planners to see what the feedback is post the commissioning. And there is very little work that is done there. It is usually given to operations managers to say, look, this is your facility, now run it. And that's when tinkering starts, when they go back to their engineering departments and say, well, you know, could we have one more of this or one less of that? And that changes the entire design philosophy with which the architect and planners had put in their initial thought and work. So it's important that it is not, we see stakeholder engagement at the time of design, we see that at the time of commissioning. But I think it has to be a continued process to have a good evaluation and a smooth commissioning, and obviously becoming more accessible to patients. That's the whole idea of setting up new facilities.
Thank you, Karan. Thank you for highlighting these points. And you know, one factor which remains, irrespective of situations we are faced with, whether it's ordinary or extraordinary or pandemic, one concern which always remains, that's the patient safety and the outcome. So public at large and the patients, their expectations remain very high on these aspects, and no one could be knowing better on these issues than Dr. Atul Mohan Kochar, the CEO of NABH, who's with us, who faced with these issues. I won't say day in and day out, actually 24/7, he's faced with that. So Atul will request your comments on that.
So thank you so much, and thank you for this opportunity. So essentially speaking, as you rightly mentioned in the beginning, that as we are emerging from the clutches of a COVID pandemic and the threat of a future many hanging over us, and as Karan rightly pointed out, the climate change is maybe the next big front leading on, or all of us, to the next big pandemics. We have to devise ways, we have to probably go back to the drawing board and see for us what works, what does not work. So currently as we are, there is no right, no wrong. Even the most developed nations have kind of not been able to deliver as was expected of them. And the only thing which can bind us together, as is emerging, for example, a country as big as ours, we are not one country, we are 36 countries rolled into one. The only thing which can bridge this big divide, whether it's infra or a provider versus providee, that is technology. So technology has to permeate every aspect of healthcare delivery. And from every care point, every touch point, starting from entry to the exit of a patient, inside a hospital, outside a hospital, remote care, technology has to be there, and fortunately the solutions are already there. The policymakers have also taken note, and they have devised the ABDM, the Ayushman Bharat Digital Mission, and NABH started to find its feet in the digital era about 2 years back, when we started to question our existence, and we thought what lies in the future for us 10 years hence. So we started to draft these digital health standards, and in probably next month we are releasing these standards. And these technology standards will outline, and they will be the linchpin around which the entire patient safety matrix will revolve. So our basic ethos, you are one of the founders of NABH, for all those who don't know. Dr. Bhatia was one of the signatories of the original document which gave NABH its existence under the QCI umbrella. But, and since that 2005-2006, all our standards revolve only about patient safety and healthcare quality. Now the time has come to infuse technology into everything which we do, and fortunately there are options, there are solutions, and they will be binding everything together. Whether it's a humble UHID or let's say one example is our number, the Ayushman Bharat Health Account, which holds extreme potential of interoperability, of giving ID to a patient, and how the data flows through top to bottom or horizontal. It will all be governed by standards and data protection laws, and all for the benefit of the patient and the poor. Technology somewhere will also bring in the equity. So what is missing in the current scenario is that we have managed to create over these past 20 years, 2 decades, islands of excellence, which are comparable to the best in the world. But we are still struggling with the patient safety goals like hand hygiene, wrong side surgery, communication matrices in the far wide nooks and corners of our big country. So ultimately, if we are to reach out to the last in the line, technology is the only option and only technology, and its adoption, early adoption, and we have that power to leapfrog others, can lead to the optimum healthcare delivery and empower all of us to fight the future challenges. So that's my small submission.
Thank you, Atul. Thank you so much for bringing out very, very relevant issues, because at the end of the day, we need to understand that patient is for the hospital is for the patient. In fact, it brings me to a very, very important dilemma, which I generally raise, whenever I'm speaking to a group of young architects or, in an architectural young crowd, that when you design a hospital, what it should be designed for? Should it be architect's delight? Should it be physician's delight? Or should it be the patient delight? In fact, in 1992, I got my National Award for Promotion of Health Administration as specialty in India. And Colonel D.B. Ray, my teacher, I just mentioned to him there's a beautiful hospital coming up in Delhi. He asked me a question: is it a good hospital or is it a beautiful hospital? Now, that dilemma remains, that is it a good hospital or a beautiful hospital? Of course, my answer is why it can't be both. When you look for your wife, what you look for? You want beautiful one also and good one also. Why don't combine them into one? Similarly, when you are talking of the hospital, is it architect delight or a patient delight or physician delight? Why it can't be all in one? So that's where, probably all the effort, all the knowledge, all the experience of our architectural team and the planners comes into, and to highlight on that, I request Brenda to please share her thoughts on that. Should the design of the hospital be designed to suit the need of the doctor, or design the facility for patient experience and better medical outcome, or enhance profitability of the hospital? So I'm added another dimension to it, the owner's delight. So the owner's delight also has to, promoter's delight also has to be a part of it. So Brenda, your views on that, please.
You've already answered it. It has to be both. And it has to include all of these aspects. So earlier on, the key term was patient safety or patient-centric design. Now it is about person-centric design or user-centric designs, which means that it has to address all the aspects. It has to definitely, patient is at the center of the circle if we have all the stakeholders on board. And patient is definitely at the center, but we cannot ignore the staff and the doctors, because that's what makes the hospital. And a lot of times what we have seen is there is a lot of pressure on, meeting the number of beds. I have many people here, I'm sure, who will agree that, when you design the hospital, meeting the number of beds is extremely important. As we go further, we cannot cut beds. No matter what other areas we can reduce. So at the same time, what happens? What is the compromise? The compromise happens in your staff areas, in your admin areas. It's like, okay, no, daylight areas, let's keep the daylight areas for, the OPD patients and for the the doctors who are the sought after ones. But what about the staff who work day in and day out? Of course, it has to be a balance. revenue and profitability is extremely important. But if we look at a design which is overall user-centric and looks at all the stakeholders in a kind of balanced way, we might be able to design a hospital which is also profitable. Again, I mean, the wife could be both. And we don't have to choose one over the other, I think.
Thank you, Brinda. Thank you so much. As I said, this is always a dilemma. You know, I generally start my talks with these questions that should the hospital be a hospital building or it should be a monument? We are most of the time trying to make monumental building and not the hospital. And of course, you know, good hospital and a beautiful hospital and whose delight it should be. You know, these are the dilemmas in which we always work around, and thank you for answering that. You know, my next question is to Preeti. Preeti, there is always now, you know, we are talking of new generation hospitals. There are so many definitions being put to the hospitals that as hospital planners, leave aside the hospital planners, you know, the people in the industry, they get confused at what definition goes to what hospital. I mean, if we say new generation hospital, what is a new generation hospital? What does it really mean? Does it change the scenario in any way? And, you know, based upon many of the geographical issues, you know, the cost and the new generation hospital becomes a kind of dilemma. So, should the existing infrastructure be leveraged to, you know, put across some of the better designs? Should the geographical location have its own role to play? Because I personally feel that the socio-economic demographics, they play a very major role in thinking of designing of a hospital. In fact, many of the hospitals, they haven't been able to deliver because they thought of going, you know, what we are talking of new generation, while they were catering to the needs of a mindset or a population where the requirements were different. And ultimately, there's a mismatch. I know of a number of institutions where we ultimately had to step in to step down the image of the organization to suit the local population. So those are the kind of things which raise the questions. So my question is to you that this new generation hospital, how their design should be impacted the geographic location, and more so, is it good to leverage the infrastructure which is already existing for such situations? So Preeti, stage is yours. Yeah.
Thank you so much, and thank you for inviting me. So, according to me, the new generation hospital is slowly, what defines a hospital or the extents of the hospital is blurring. Because now with technology, people have access to healthcare even from the confines of their homes. And also, now is the time of decentralized healthcare, so that, healthcare is made easily accessible to the community. And also wellness is going to be a very important aspect of all of this. Focus on preventive medicine. So it's not that, hospital is looked at as a place where you receive treatment, but also it becomes an extension of the community so that, wellness and preventive medicine become a very important aspect of infrastructure. And in terms of using existing infrastructure, I know that, just going back to your previous question, developing a new facility or, designing a new hospital is very exciting for everyone that's involved, including the architect. But developing a new facility or creating a new building negatively impacts climate, budgets, and also timelines. So a good strategy to look at is, taking a stock of what is existing and can that actually be reused. So that's where adaptive reuse or retrofitting existing infrastructure comes into play. So we have buildings which are well designed and, they have a good lifespan. Buildings are designed, to last for 50, 60 years, or even, some of the buildings have lasted for more than 100 years. So looking at that infrastructure, also looking at the aesthetical value of those buildings, and looking at the prime location of these buildings, and seeing if, the buildings that are not being used right now or, are in derelict, can they be used for other functions? And all of that actually, from a healthcare perspective, becomes quite crucial because cost is a major concern for healthcare. So putting to use existing infrastructure actually brings down the cost and also gives you huge benefits in terms of timelines. I would like to just quickly talk about two examples that our firm Canon Design has developed, and we've worked on several retrofitted hospitals or adaptive reuse projects. So one is for the Northwestern Medicine University, and that's a big name. So they do have huge setups, huge hospitals in the US, but actually making it accessible to communities which are underserved was the focus of this group, this particular group. So what they did was that they looked for infrastructure, existing infrastructure. They found a mall, Bloomingdale's Mall, which was underutilized, which used to be very vibrant at one point of time. They found this place and they actually converted that into MOB, medical office building, or an outpatient clinic. And there are a lot of things working well for this facility is that the building, it has high ceilings, it has a robust skin, and high ceilings and the large space actually helps you in designing flexibly. So we were able to actually, Canon Design was able to combine adaptive reuse and modular technologies to be able to actually create modular exam rooms within that facility, and that's quite well used, and it actually brought healthcare much closer and made it easily accessible to an underserved community. The second example is CHOC, that's Children's Hospital of Orange County Autism Center. And this was actually a bank building that was converted into an autism and a neuroscience development center. Again, very close to a community that served the population that lived around that area. So this actually focuses on helping children as well as their parents navigate through early education years of autistic children. And it also helps them get to resources which help them navigate their day-to-day lives easily. And it's very beautifully designed. And again, why should we compel children to, get into a big hospital for adults and, into a scary space? So, finding these facilities which are closely linked to the community is, I think, a very good way of looking at it. And that, in a way, destigmatizes healthcare and makes it more accessible. And, there are opportunities to include wellness into this whole scheme of things. I think that would be great, if that could happen.
Thank you, Preeti, because this is going to be, one of the questions we are asked many times, not only for the hospitals, but medical colleges, because with number of defunct engineering colleges available, a lot of engineering colleges want to convert themselves to medical college. And obviously, the first question comes to building up a 300-bed hospital, which NMC requires. So is it possible for conversion of these existing institutional building to medical schools building? These are the questions which are coming up again and again, and thanks for answering that. While we talk of hospitals again, one thing which you find common in every brochure, you open the website, you open the brochure of any hospital, healthcare institution, one word is common: state-of-the-art technology. I've never been able to define what the state-of-art is, because today the technology changes. By the time you spell the word technology, the technology has changed. Mr. Nair talked about linear accelerators. I remember my days at Rajiv Gandhi when we installed first 2 linear accelerators in the country. Since then till today, that's about 25 years, the linear accelerator technology has undergone change more than 20 times. So practically, the technology has changed almost every year, every alternate year. Similarly, talk of, let's say, simple thing like CT scan. from the conventional to spiral, from two slice to 256 slice and onwards. The journey has been phenomenal, and we don't know where to go. I'm sure as architects and planners, we also have the same situations. Where is the technology leading us? When we plan the hospital today, and by the time it gets completed, the technology might have totally changed. So how is the vision for technology? I think Manu is one of the most experienced person in the field sitting with us. So Manu, a question, a difficult one to answer. What is your technology vision for the future when it comes to resilient, safe healthcare infrastructure?
Thank you, Dr. Bhatia. So I'll take a step back on this. I mean, ever since I've been designing healthcare facilities, there are three things which have constantly remained, which have been constant all throughout since we are doing the projects. And they are, one being the efficient planning and design, which essentially translates that every promoter wants to build a hospital which is coming at the lowest possible cost in terms of infrastructure. The second being, to ensure that the buildings are sustainable and green so that your operational cost, that is OPEX, can come down. And third, as my friend Karan was just talking about, about the gestation period being longer. So you really need to design facilities which can be built faster so that built faster and as well as flexible so as to kind of adopt to the ever-changing requirements of the healthcare facilities. Now, we at RSMS kind of, leverage the technology. So, I mean, I'll answer the technologies. We leverage it from design stage through construction stage and then post-construction stage, all three of them. So during the design stage, we are using a lot of softwares like building information modeling, which ensures that, the RFIs from the site and all of that is less, the clash detections are sorted, everything is drawn in 3D, especially the stuff which is going above the ceiling. So that kind of eliminates a lot of things. The project can be tracked in real time. From bringing the second cost down, so we use a lot of softwares like Safaria and Energy Plus. So as to, because in urban setup, it is not always possible to kind of design buildings which uses the passive ways of controlling the energy requirements of the building, and hospitals being energy guzzlers. We use these softwares to kind of design fenestration, select glass, etc., etc. And the most important point, and directly coming to your question, was that we have to design facilities. The structural cost of the buildings is humongous. The codes, structural codes are also getting revised very frequently these days. Once in every 5 years, the structure code gets revised, the new one coming in next few months. And hence the structures also which we are designing today, to bring down the cost, we are using a lot of technology like dampers and foundation isolators, so as to ensure that the building can be built faster, one, and also the structural cost can come down. And use, drywall partition system, modular spaces are designed basis that, so that the adaptability and the changes in the technology which is coming up can be incorporated with these without disrupting the functioning of the hospital. So these are some of the ways, we can mitigate the changing requirement of the healthcare. As we were talking the other day, the technology of building operation theaters. I was talking to Dr. Bhatia that, how the operation theater scenario has changed from late 90s till today, from designing hospitals or operating rooms with granite and epoxy coating on top of them, and then switching to modular OTs, and then now including the robotics into it. So the whole dynamics of technology is changing, and hence if we design facilities which are modular, which are flexible in nature, by using the latest materials available, I mean, Western countries are already following that. If we can incorporate that to some degree, keeping the cost impact in mind, because our country is quite cost sensitive. So I think we can mitigate all of this and design better facilities.
Thank you, Manu. I totally endorse your point of view that there's a phenomenal change in what we have done in last 3 decades. I've been into, this part of, activity for almost 3 decades now. 89, when we were doing our first hospital, we didn't have even the vinyl flooring available for the place. Forget about modular. The modular theater we had seen in some of the exhibitions in Hong Kong or Singapore or whatever it is, and thinking about it over here and now you are possibly looking at, what better you can do with the modular theaters. All the time there are situations coming up. So we need to understand all that. I'm coming to the next point of it, where it is little related, but how much we understand the importance of it is a question mark. That's the lighting. Imagine this room with no lights, and imagine this room with too much of lights. The too much of light over here could be offensive, and too little light could change the environment of this room from a study center that we are talking from here to a nightclub. So that's what the difference it makes. And in the principles of evidence-based hospital design, I think one of the biggest factors that is being talked about is the lighting. So we have one of the real experts, who can talk about it. Nikhil, I'll request your opinion on that. How can lighting help create a more sustainable and safe healthcare infrastructure? I mean, as I understand, this is one of the most important components, and your views will be of most enlightening to all of us.
So, thank you, Yashji, for that question. Now, I'll break this into two parts on sustainability and safety. On sustainability, as the lighting leader in the world, we believe that lighting is important and essential for any sustainable building to be made, and in healthcare it's no different. Normally, lighting takes up to about 10 to 15% of all healthcare energy consumption. And with the advent of LEDs, already we're seeing about 80-85% efficiency coming into lighting, and thus reducing cost of operations for any hospital to run. But by incorporating a little more on controls and sensors, we can actually reduce or increase this efficiency up to about 95% levels versus conventional technology that is there still in some of the older infrastructure. Something very simple as a motion detector in a storeroom or in the stairwell can just switch off the lights when obviously this area is not in use because it's not a critical area. Similarly, Brinda talked about design, right? We are now designing a lot of hospitals with natural light. Now, just putting daylight sensing there ensures that you can dim the lights and not use those lights when not required. You are natural light. And this further reduces the consumption of energy and thus obviously cost of operations. On safety as well, Atulji talked about the upcoming, using technology for safety, patient safety. Now, I don't know, a lot of people may not be aware about Li-Fi. It's when we are using lighting to actually transmit data. It's an alternative to Wi-Fi. It does not use radio waves, it does not use microwaves, it uses light to transmit data. So it's free from any electrical encumbrances, especially in a hospital environment, which has sensitive equipment. Also, this is a very low latency, high speed data transfer. You can achieve speeds up to 100 Gbps, which is unheard of with Li-Fi. And what it does is that in the new age and new infrastructure of telemedicine, especially in case of emergencies, when we need a very low latency, high speed, secure data transfer, Li-Fi can be a very suitable option for telemedicine or robotic surgery, which is being remotely controlled. Li-Fi is also much safer because you transmit the data only to the machine which is actually going to use the data. So unlike Wi-Fi, which is accessible to people outside the hospital premises or somebody on the hospital premises who's not supposed to get access to that data. Li-Fi allows us to transmit the data, especially in case of, let's say, real-time patient monitoring that is happening in hospitals. That kind of data you would want it to be securely transmitted. Now, so I think there's a lot more use for lighting that is coming up in infrastructure for healthcare, both in terms of sustainability and in case of patient safety.
Thank you, Nikhil. Thank you so much. I think the lighting is one area where I am sure you can keep on talking for hours and still there will be more to talk about it. And so expecting you to finish it in 2 minutes was something really difficult. We'll have one more round of questions, but I'll request, just 1 minute, 1 to 2 minutes for each, and before we close. My first question is to Karan again. And Karan, I would like you to spell out, suppose you are going to build up a new hospital tomorrow or think of a new hospital tomorrow, what will be your key stakeholders who will be influencing the design? Of course, we have discussed this question even earlier, but, from a process point of view, your thoughts.
Yes, I think the strategic team that is looking at a new hospital would need to bring in a whole host of people, and I can list all of them, and I still miss some. But obviously the viability team, which looks at whether this market is suitable for the type of vision that a person has in mind, will drive the hospital design. But beyond that, the clinical facility director, the clinical teams, these are both admin and practicing side, nursing leadership both on the administrative side, and clinical practitioners who are going to be delivering care are going to be important. Brinda raised the point about staff rooms getting smaller or disappearing, because of demands from the clinical side is very important, because we see that, when we design facilities, we make very nice bathrooms and we make very nice public areas, and there's no janitor's closet. And that's where, if we don't have the voice of the housekeeper, of the facilities people, we will not think or orient ourselves to their needs. And that also has an impact on outcomes, infection control, etc. I would go right down to the level of our security staff, because safety starts from physical safety, and without bringing them into the fold, we will not be able to design a good facility. But the biggest stakeholder is the patient, and I think we should conduct surveys of areas where we're going to be setting up hospitals to ask them what is the type of facility they would like. That's a social license we need to operate when we start a hospital.
I would add on to that. Generally, when we do our NABH, we always tell people that chairman to doorman, everyone has to be involved. But here we go one step further, where we say that all the customers of the healthcare scenario are the stakeholders. Now, who are the customers? Are we able to identify the customers? In fact, I remember my old class of MBA, when I was doing it abroad, and we were asked this question on a very small, hilarious note, that when you are designing the Pampers or these disposable for the children, who is the customer? Someone said it's the father because he pays for it. Someone said it's mother who decides on what diapers we buy to buy that thing. But my teacher, he said, what about baby's bumps? Because baby's bumps are the ones for which you have to design the diaper. If it doesn't serve the purpose over there, then it doesn't serve at all. So that's where, identification, because in our scenario, the stakeholders, right from the regulatory authorities, my first stakeholder is regulatory authorities. The whole system is designed for regulatory authorities. If I don't do that, I don't reach anywhere. My next stakeholder are my payers. Tomorrow I have to design, because ultimately the third-party payers are going to determine what they need in the organization, the community, and many such other things which are going to impact. Your physicians who are going to be working with you. You provide an operation theater where you can't do the robotic surgery or the transplant surgery. Tomorrow you want to attract a physician to do the robotic surgery. He says, I don't come because you don't have the facility. So, a lot of these factors. So stakeholders become multiple, and they have to be taken care of while we are working in the organization. So I think best at any stage is list down the stakeholders, A, B, C, D, E, F, G, you'll find A to Z, you'll find so many stakeholders. And are we able to identify the needs of them and put them into and don't forget the baby's bumps, they are important. They are ultimately the ones. What it really means, the micro planning has to address the micro things which we may not imagine at our design stage. Atul, I'm coming to a very question, which is had many heads rolling also, even at the top political levels, the oxygen crisis. The oxygen crisis which came at that time, when we were in the peak of the COVID. And I think anyone in the healthcare industry would, not only the industry, even the community will endorse that everyone went through that particular stage. Now, that struggle, where government mandated rules for hospital to apply oxygen generators within their facility, what are the challenges? What are the things? Because now many of the organizations, the generators are there, but those generators are lying, practically unutilized. And even if they are being utilized, they are turning out to be such expensive energy guzzlers that people are thinking that whether it's a folly to have them or it's a use to have them. So your views on that?
Yeah, thank you, sir. So essentially, we were, caught unawares, I think, as a nation, and probably some other nations like Italy also. So this was a all-pervasive crisis which happened, but all for better, I believe, because ultimately at NABH also, we've also always raised a huge concern about continuity in care. So our standards address the issue of alternative arrangements, whether it's water or power or manpower or human resource. So everything should have a plan B. So that's what standards imply. So during the crisis also, we were one of the very core teams on ground which were helping the Government of India. The effort was coordinated by PMO. And the entire effort was to deploy 1,200 PSAs, about 5 lakhs concentrators and millions of other things also. So I think it's a good idea to realize that one option may not suffice, and one should, in as critical a matter as oxygen, always have a plan B. So while we all acknowledge that LMO is the best, it's the purest form and has to be there, but a plan B should be there, especially in remote areas or underserved areas where there's an option or there may be a disruption in taking the cylinders there, or access control may be there. Then it makes sense, if despite energy challenges, to have a PSA plant there. So we all realize that,
right.
And even concentrators. So ultimately, whether it's a home care or remote care, and I think the challenge here is to address the issue of technology which is powering the PSA, and probably tweak that to make it more viable.
Right. What I also feel, that at that time when these equipments were brought in, they were brought in a hurry. And at that situation, the technological component or technological part of it was really not kept in mind. Now that we have time, we have, between the war, there is a peace time, and the peace time is to utilize for the preparation of the war. That's what they teach us in the army. In the armed forces, we were always that the more you prepare yourself in peace, better you are equipped to fight the war. So this is a time that, we have to be looking at that technology, that, as I said, they are becoming energy guzzlers for the organization. Can't we have better technology, and can't we have modification of the present technologies? Because earlier ones were assembled in hurry by bringing some component from some country, some component from other company, and just put in piece to have that together. I think now it's some time to bring them together. And that brings me to a question from Brinda, that your organization is working in multiple countries and various places. What are the challenges in India?
This requires a lot of time, but I'll try to be as brief as possible. We are working on a lot of international hospitals at HKS, and we are also working in India. But there are challenges in every country. It's not like it's a different kind of challenges, and India is a very, very unique market. Our public infrastructure for healthcare isn't as robust as it is in some of the other countries, and hence the reliance on private hospitals is much more. So the challenges, just to list down a few. First one that we face a lot while designing is that the regulations for designing a hospital are very different in all the states. The NBC has tried to unify it, but even the interpretation of the National Building Code varies from state to state. So for anybody to figure out what is applicable and what works, it not only differs from a state to the state, it also differs which licensing architect you're working with and who is the person at the government office at that time who's able to pass that regulation. So that has been a struggle because internationally we see a lot of these codes are being regulated and there is a standardization in that. But this interpretation makes us lose a lot of time during the design process and also later in construction when we realize that something is not possible. Some of the other challenges similarly in terms of technology and infrastructure also, like we have NDMA, which is the Disaster Management Organization, and they have some construction techniques which are prohibitive, such as the precast and the prefab technologies. And in India also we saw a lot of that being used when the pandemic struck, and those were kind of accepted because of the emergency situation. But construction technology also needs to evolve in terms of what is the need of the hour. So maybe these are certain things that we can look at, and these are the challenges that we are facing. Interaction with MEP engineers, even vendors. We earlier talked about how technology has evolved in the last 25 years. If we are doing a proton center or a linear accelerator, it is very important to know who's the vendor right at the very initial stages, because CT and certain other equipment you can still work around. But some of these equipment you have to know what is right at the beginning. So maybe there could be some standardization that could happen across the industry, even in the equipment aspect, not just the design. So these are just some of the challenges, and then of course the pressure on cost and doing everything in a cost-effective manner. A lot of times we see clients, they tell us, they don't really discuss the budget initially. And we kind of keep asking, what is your per square foot cost, or what is it that you're willing to spend? Then what happens is that management approves a certain design, but then it gets value engineered. And it gets value engineered much later in the day. And that time, that value engineering actually does not really reduce costs, because it has so much rework involved in it that the project then stalls for a long time. So we are not able to meet the timelines anymore. So just looking at the big picture holistically, giving a little bit more time at the design stage so that things are right at the beginning, all the stakeholders are aligned, even if it means spending one more week extra maybe to check all the boxes, make sure it's as per budget, would really help. And that in India requires not just, of course, the designers, but also all the stakeholders that we were talking about. These are just some challenges when we were working as HealthCare, and when we are working in various countries and in India. We've seen delays and project stalling because of these aspects, and hopefully it will get better.
Thank you, Vinita. I think you are absolutely right on dot. We are expecting, not only we, our regulatory authorities, also everyone is expecting the global standards at the Indian costs. And that's where is a challenge coming up, that a lot of innovation is required to meet, and rightly so, because ultimately, when it comes to the payers' paying capacity, that is linked to, even if it's a government hospital, there's a paying capacity of the government to pay for the services. So ultimately, that is very much linked to what it is. So if you keep on going with only global design and start putting over there, every single hospital will be a non-viable hospital. So those are the, I think, innovation challenges for the designers, which it is there that we are required to deliver the good outcomes at the prices which Indian economy can afford. And that brings me to a point of evidence-based hospital design, Preeti, that, I've myself been a student, and I won't say teacher, but a speaker on hospital evidence design quite a bit in the global scenario. And I very strongly believe that evidence-based medicine cannot be delivered without the evidence-based hospital design. So can you enlighten a little bit on that, please?
Yeah, thanks for bringing up this important topic. So I'll start with the definition of evidence-based design. So that's the process of basing design decisions on credible research for better outcomes. And in the context of healthcare, it's better healthcare outcomes for healthcare providers. So the whole premise here is to link the relationship between the physical environment and the impact that it has on aspects such as patient safety, staff and patient stress levels, and also safe healthcare outcomes, patient recovery time, and generally better outcomes for the hospital as a whole. So Dr. Roger Ulrich, who also happened to be my professor at Texas A&M, he was considered to be one of the pioneers in the field of evidence-based design. And one of his seminal studies involved studying patient rooms for post-operative surgery patients. So he actually conducted studies that compared, patient rooms of different, designed differently. In terms of the only difference was the availability of a window and what the view was offering. So he compared patients which had a nice view to a very scenic outside, which comprise trees and plants and a lot of greenery, and another set of patient rooms that actually looked into a brick wall of a neighboring building. And they actually studied the amount of time that the patient spent in the hospital, recovery process, the recovery time, and also the number of pain medication or the amount of pain medication or analgesics that were given to the patient. And what the studies indicated was that the patients that were in rooms that offered good views to the outside and nature actually had faster recovery and had to depend less on pain medication. So it's for architects, we would like to think, and we strongly also believe, like most of us believe, that there is a link between our design decisions and the physical environment and how that impacts several aspects of healthcare. In the US, why it all gained a lot of traction is because of rising healthcare costs due to hospital-acquired infections or nosocomial infections. Also falls, that's patient falls within the patient rooms. And, a lot of things that could actually be linked to a hospital that is, probably carelessly designed, or an environment that is carelessly designed. And, a lot of these things could actually be improved by making certain, small design moves. So yeah, I think it's a very important topic. Unfortunately, right now, all of the data that's available as evidence is focused on Western countries. So we do have a lot of data in the US and Europe. It's high time that we started focusing on that in India as well. India, we have a huge population, different types of healthcare facilities, different geographies, a lot of critical mass for research and evidence, and that should actually be utilized for our benefit, so that we need to stop and think about the facilities that we have created and how they have performed. So this is like one step going beyond post-occupancy evaluation, which is also a very important aspect, but actually taking it to another level and creating a database of evidence that will also help future facility providers and architects to come up with better designs as a whole.
Thank you, Preeti. I absolutely endorse your point of view, and almost more than 2 decades I've been trying to talk about it in every forum, so that more we are aware about it, more it will get incorporated in, when we are talking of design follows function. This is one of the first principle, and if that principle is to be followed, then we have to identify these evidence-based needs to put the design in place. I'm sure, as everything else, the system is evolving, and this will evolve further. Taking it further to one more higher level on the evidence-based hospital design, Nikhil, your point of view, how does the lighting impact the patient safety and the outcomes? How it's going to be important in the organization?
So I was wanting to go after her because somehow I had the same discussion lined up for myself. We were talking about providing a window to a patient and how it impacts his recovery. Lighting is very important to all of us as humans, right? We have an internal biological clock, daily clock, which is basically the circadian rhythm. It tells us that it's night, you have to sleep, and it tells us it's morning, you have to wake up. Of course, it's driven by chemical reactions, and I'm not going to get into biology here. But we have a HealthWell solution which is designed for healthcare facilities, which basically mimics the circadian rhythm of the sun and basically controlling light, color and intensity, just like the sunlight is. That in morning, the kind of light that we have during noon, evening, and of course during dusk. And we've implemented this across hospitals around the world. And third-party research has shown that it has led to quicker and longer sleep cycles for patients. This is directly related to their recovery and outcome. Also, it leads to the same survey also showed that patient satisfaction as well as staff satisfaction was up in rooms that were actually fitted with this kind of technology that actually mimics the circadian rhythm. Another thing that we have is a Nature Connect fixture. Now, we would love to have a window in every room, but normally that's not.
Improving your operational excellence, improving your operational efficiency, accuracy. So this is what is the digitization. I take it into a digital world that way.
Very simply put. Thank you, Arun. So now next question comes to Dr. Sushil Meher. He's CIO of AIMS, the premier healthcare organization of the country. Dr. Meher, these two terms are very fanciful terms that are often being used. One is smart hospital and second is connected hospital. Now, can you please demystify these two terms and how these are helping in healthcare?
Initially you have talked to, explained about the digital transformations. Just I want to put 2 lines on this. Today's days, in each and every domains, people are talking about digital transformations or digitizations. You have to distinguish these 2 terms. Digital transformation is something different than your digitizations. All the records are digitizations, means it is in the computer, it is in digital forms. That's all. But what is the digital transformations? You have to understand. Just like earlier you are booking your cab from the phone. Right now you are booking your cab through Ola and Uber. Some apps you have. You know the locations where the cab is there and what is the charges is there, how much time it will take. It is called digital transformations. And another term I am talking about, the digital modernization. Is it the same, the digital modernization and digital transformation? No, it is again also it is not there. But I am not come to that things because my talk will go more time. You are talking about the smart hospitals. Yeah. Why you need a smart hospitals? Because it's the convenience to the patient that how convenient he is when he will reach the hospital. And what is the patient basically? Patient demands at any moment, at any time, anywhere he needed healthcare services. And you have to facilitate them automatically. How? First time in AIMS, we have started. This is the first public hospital where we have started the appointment system through call center, through apps, through a website. This is the first time we have started in 2010. But the problem is that the demand and supply is so high. We have to put some business logic that appropriate people should get right kind of treatment and right place and they avail the facilities. Right now we are getting 12,000 patients. And in the morning you will find 12,000 patients in one floor. And you know it, that each patient has 1 attendant or 2 attendants. So about 30 to 35,000 people are on the floor. I have to manage everything, sir. Another aspect, my demand, what we have calculated, it is around 45,000 per day we needed it, the OPD slot. So when demand and supply has a gap, definitely there is some other way around people try to get the service. And we have to make more transparent. And digitization is the best option for do it. So what it is that, what he was talking about smart hospitals. When patient is coming 12,000, about 4,000 people coming with their own car. Where the car will park? So right now we are planning to process, we have to improve the process. When we are taking the appointments, you take a slot of your parking slot. When patient has reached, he need a wheelchair or a stretcher. And when he come, he'll search for wheelchair and stretcher, it is a problem. Because the campus is so used to move around that some patient may need the wheelchair. So you can book also wheelchair also through your appointment systems. Simultaneously, when you will reach, right now we have started, come here and scan our QR code. It is pasted in the OPD floor. Then automatically it will be ask your Aadhaar and it will be registered through authentication from Aadhaar, and your Aadhaar ID will be created and AIMS ID will be created automatically. It is not required to go to the counter. And go to the kiosk, take the print of sticker and put your sticker in your OPD card. This is the smartness. It is not required to take any intervention from the counter. So this is the patient experience. Patient is coming, he has the appointment number and he's scanning it and he's going to the room number. So this is the one type of smartness where you are getting your parking slot, you are getting your wheelchair or stretchers, and you are getting your registration without any help from anyone of the counter. Second smartness I am talking about it, the labs. This is the only lab in the Asia first we have installed in 3 years back. It is fully automated. The pre-analytic, analytic, and post-analytic is totally automated. And per hour, we test around 12,000 tests in that system. Only the intervention is that doctor has to give the order entry, and you have to collect the sample. That is the manual. Rest of the things are automated. All the samples, it will move automatically through a conveyor belt. It will go to the pneumatic tubes. It will go to the particular labs. Automatically, that container will go to the acceptance block, and that sample will move again conveyor belt, and robotic hands pick each tubes and put in the particular machine for test, and all are without any manual intervention. Yeah. So this is the smartness of the labs we have. Thank you for that. Yeah.
So enough practical examples, and thank you for being on the ground. See, I will just summarize what Dr. Meher just said. There are two words we were using: smart hospital and connected hospital. So what all examples he gave, smart means eliminating the manual effort wherever possible. Let things run automatically. You see, you might witness, several dozens of registers and forms being maintained, filled, and transcribed by different people, creating lots of opportunities of error everywhere. If you have a smart workflow, smart system, you need not worry about writing all that. It saves a lot of time. Nurses can devote that time to patient care. Connected hospital is a very different concept. So I just saw one video in 2014 that was by Cisco, and it was very appealing. See, what we are doing in this country today, all these hospitals, we are not really doing healthcare. I say this in several forums. All we are doing is health repair. Once it has already gone wrong, we are trying to stitch and fix it. Healthcare is that now we are having wearable devices, we are having all smart watches. It is constantly observing the status of our health. And the moment any signal comes from body that there is a problem, without the patient experiencing or the person experiencing, a signal automatically goes to the command center. Nearest hospital is triggered, and that hospital automatically sends the ambulance to the place where that person is having an exercise. Cardiac arrest is in the coming, and the person is already taken to the ambulance and treatment starts. Now we'll be able to save the life of that patient because all those equipments are already there and it is connected to the emergency of the hospital, right thereafter connected to the ICU of the hospital if required. So that is connected in smart hospitals, just taking further from your examples. So I have another question now. The question is, see, people worry about one thing, and this is very consistent and constant. When we computerize, digitalize a process, now we become totally dependent on that computer and network. God forbid something happens, and I tell you a practical example. Couple of my colleagues are sitting here. We were on the way to this place, and we received a phone call that one of our hospital information servers is down. Now you can imagine CIO taking the even middle management along with him, so irresponsible, and server is down there. Now what will happen? Luckily we had a resilient server, a high availability server. That server was working, and we could, while on the way, diagnose the problem, and by the time we reached here, we could fix the problem, and the second server is now up and running. So just giving you an example, nothing great about us. There are a lot of examples that all of us have in our day-to-day life. But what I can tell you, the question is, are we really safe and resilient while digitalizing the processes, and how it is improving the resilience? Because manual system is now ensuring that, okay, if one person is not there, other is there, one process is not there, other is there. But in a computerized, digitalized process, how we are improving resilience rather than compromising on? Dr. Mayor, again to you.
Yeah. See, when we have gone for a fully automated hospital, you are totally dependent on your patient records from the data which it has been stored. And if the server is down, or storage is down, or your network is down, or some things it has happened, it may be some cyber attack also. So you're supposed to have a provision that how you will be resilient to come up. What we tell in business continuity programs supposed to be in place. Definitely, if you need a high availability, in that cases, we're supposed to have a second-hand setup. If the primary server is down, the secondary servers, it will take care of that. Even also your storage supposed to be have another high availability setup supposed to be there. Let's one example I'm giving you. Let's take the main servers which you have the OPD and your appointment system is already running there, and it is down in the morning. And a lot of people in the morning, they have come and for their registrations and the other things. What to do? So you have to take a call on it, that how much downtime I needed it. Based on that, you have to take a solution on that. If you want the zero downtime you needed it, the cost will be very high. If you go for half an hour, that solution is different. If you go for 2 hours, that solution is different. Because when you configure two different servers, it will talk each other. It is called heartbeat configurations. When each server is fetching its data, automatically same data will fetch in another servers automatically in milliseconds. That should not. So when this server is down, and you want that zero tolerance, in that cases, automatically that server it will come up without your knowledge. Just the server administration will know that the primary server is down and the secondary server is up. Yeah.
Excellent. So Dr. Meher has touched upon three things now. I'll tell you the jargons. One is BIA, second is BCP, and third is DR. So it's touched upon business impact assessment, how critical what business piece is so that he can build the resilience along it. Second is having a disaster recovery plan with proper recovery time objective and recovery point objective. People talk about RPO and RTO, right? And third is having a business continuity plan if everything else fails, how we can still continue delivering healthcare through manual processes. Now coming back again to the smart hospitals. So the prerequisite of the smart hospital is that we have a very resilient internet line. That connectivity, if it is not there, then we cannot think about the smart and connected hospitals. So I will come to you, Mr. Vishal Gupta. You are here, okay. How can we ensure the reach and accessibility of different remote places to have such a mission of giving connected care to the entire country?
Good afternoon, everyone. Good afternoon, JP sir. So, first of all, India has already, kind of witnessed a tremendous growth in terms of internet penetration. Now we have almost, I was reading just before coming, it is almost 600 to 700 millions internet users, and that internet I don't consider kind of a excuse, in terms of adoption of digital health ecosystem. Second thing is, what I firmly believe is digital health ecosystem is something that should comes through the demand, through the ecosystem, and not through the policy enforcement. So it's the same principle, the way, we have seen the growth of social media, the WhatsApp, Facebook, and all other Paytm and other things. So if there is a ecosystem is built, then automatically there are users who is adopting, and internet is no longer an excuse. But still, the government is doing so many things. For example, if you see the digital goods system which is created by the government, it is providing a concept of which we call the no internet or limited internet. Similarly, we deployed, for example, I went to Ladakh, AIMS, Shushil, and then we saw that most of their system is capable of no internet and limited internet functionality. So they are working in a concept of batch mode. So whenever there is a internet issues, but EMR is still working, EHR is still working, and wherever there is a connectivity, they send the data to the main CDAC hub. So these kind of systems, these kind of innovations, lots of states are doing in terms of wherever they have the connectivity issues for the rural area. Similarly, eSanjeevani has developed a kind of a platform. If you have a kind of a limited internet, then still you can have that kind of EMR accessibility, and then whenever the connectivity is up, you can start your online teleconsultation. So there are so many efforts which government has doing. There are so many systems which is already built to support the low internet and limited internet.
Thank you, Vishal. So there is a reason I asked this to Vishal. In fact, Arun and Vishal were the people who were involved when foundation was being laid for Ayushman Bharat digital mission. That is why I'm telling that this is a very power-packed panel. And I'm very thankful to all the listeners, delegates, for paying careful attention to this. Your every minute will have a value. Now I'll come to Bisht Saab. And I feel so good whenever I see him in the vicinity. A spiritual, calm person. And of course, why will he not be? He's from Amrita. So, Vishalji, I heard you in a previous panel discussion talking a lot about cyber security tools and technologies. Now I'm moving slightly away from my promise that we will not use jargons. Now we will. So, for you, Praveen, question is that now as we are getting interconnected, as we are working country as a one whole or well orchestrated family of healthcare delivery system, what all cautions we should take while exchanging the data, what all risks are there, and what all technologies are there to mitigate them please tell this forum everything that you were telling yesterday.
Okay, thank you again. Thank you for the opportunity. So, as you very rightly said, as more and more data is digital, it gives us the benefit of ability to exchange it, sending it from one place to another, and that's one of the benefit that technology brings. If it is a written data, only person having that piece of paper will be able to access the data and utilize it. But with digital, you can communicate and you can have multiple people accessing the same data at the same time. So that brings the opportunity part. But at the same time, that also becomes a threat, because what if a wrong person, is able to get an access to it? So that's a dual-edged sword, and we have to be very, very careful with that. And now it's not just the basic endpoints. Typically we would say the end users are the endpoint, but like Arun and other people were mentioning, with the IoT, every single device is also connected to internet. So the threat, the complexity becomes much, much more, and we have to be extremely careful. So in terms of how to prevent it, first is to have a well-documented policy as to what those possible threats are. Because there are the different type of threats, and the number of threats are also increasing, dramatically as we move more and more into digital space. So, for example, you can talk about endpoint security, you can talk about network security, you can talk about application level security, and all these will have different set of tools, different set of programs that can help you to, one, monitor, and then if something is detected, which is anomaly, then how to react, respond to it. And again, there are many tools, and yesterday I was mentioning few names, so I think that's what JP sir is referring to. So for example, SIEM is Security Information Event Management. Essentially, every time somebody is trying to access some information, and a record is maintained, a log is maintained. But then there are so many people accessing so many touch points that data itself become so huge that unless and until you have a program monitoring that, it's humanly impossible for you to go through the log and try to see ye suspicious ho. So that machine only has to do that work. So then there are concepts of AI, machine learning, which is able to go through the data, identify where are the possible threats, identify suspicious activity, and then act upon it. It could be if you find some specific user trying to access which he is not supposed to, maybe isolate that user. And that has to be done again automatically. If you believe that you have to have, we were talking about how critical it is. So we all understand that digital data is very, very critical, and we want it to be very, very responsive. We don't want a user to intervene and then isolate a particular threat. So in that case, yes, it has to be again automated, and then there are systems like SOAR. So that has to be also planned for, because all these events are just too many. You talk about spyware, you talk about malware, you have ransomware, and more and more opportunities are seen by these cyber attackers, and we have to be extremely, extremely careful. So it has to be, again, well thought policy making, and then accordingly you have to implement the right tools to be able to detect, and then if there is a threat, then act and respond accordingly.
Thank you, Praveen. So you talked about SIEMs or Yuba. Excellent. Network analytics, behavior analytics. Himanshu, now I want you to imagine that you are CEO of a smart hospital. Okay. How will you envision the role of a doctor, a patient, and a society?
Okay. Difficult for me coming on to the technical person, coming on to the functional side of it. But first of all, my definition of a smart hospital is different. So I foresee it as a three-layered architecture, which essentially means wellness, preventive care, and then secondary or tertiary. That's what you were also referring to. Okay? So three parts of it. The first and foremost thing is that how to keep people away from hospital using wellness. So now, right now, the wellness itself is running on its own,
without a proper support of real world clinicians or real world people who understand the details of the diseases and how to keep the people actually alive and fit. So part one, how your hospital is going to a digital transformation so that it can support the wellness. Then the preventive care, which essentially means that the people who are not so ill, the basic things, sneezing or flu, general fever, they should not be coming to hospital. Either they are able to get the necessary treatment away from hospital from their comfort of their homes, or the local clinics which are in the remote areas and fully supported by the larger hospitals which have the battalion of experts. So that when it comes to the secondary care or the tertiary care, the pressure on the hospitals reduces and they are able to service more critical people rather than having a OPD of 10,000, 20,000 people in a day and not doing proper justice to other people who are in more need of these doctors within, within our country or within that vicinity. So I see the smart hospital from that point of view.
Excellent. A truly CEO perspective. Primary, secondary, and tertiary care. Now, Himanshu, one more follow-up question for you. See, people are worried about, when we hear about the smart and connected hospitals, one biggest deterrent is that probably it must be very expensive. So, are there any tools, technologies that are cutting this cost, and is it really a myth or really it is very expensive? How do we go about it?
Honestly speaking, as of today, it is expensive. And the technology companies are coming up with the innovative ideas, innovative solutions to reduce on the cost. So few of the things which we can leverage are the low code solutions, which essentially ensures that it requires lesser bandwidth to service, whether it's an internet bandwidth, it can run on 3G kind of environments, 2G kind of environments, so that the reach is to the far, far away people. Second thing is that infrastructure. When I say infrastructure, IT infrastructure is pretty costly. Now, there are solutions for the smaller setups. They can go for cloud-based solutions so that to reduce the cost of internal IT infrastructure, the costly servers, data centers, not everybody can maintain the data centers on their own. So obviously there are offerings in form of IaaS, which is infrastructure as service. Then there are things like software as service, cloud services. So all of these are very much available, and by virtue of this, you can reduce the cost.
Excellent. So that typically means leveraging of the infrastructure and leveraging of the human talent to take care of the cost element.
One more thing just I wanted to add that there is still a big what you call responsibility on the technology companies to come up with furthermore better solutions. For example, if you look at telecom industry, everybody is using GSM, right? Now, when you are implementing, whether you are using Airtel or Jio or whatsoever, you do not require different infrastructure. Everything would remain same, only your provider is going to change. So similar sort of standardization has to come in our hospital technology as well.
Excellent. So ET business, you have responsibility to carry this message to the tech companies. Are there any questions we can take?
One point.
Yeah.
I would like to.
Yeah, please.
It will not decrease the cost of the IT. It will also improve the accessibility to the patients. It will also improve the affordability to the patient. Being telemedicine, we know that 70% of the Indian population lives in the rural area, and 70% of the hospital infra is confined to the tier 1 cities. and there is a huge gap for the accessibility. The technology or digitalization or automation can help in that, providing the basic at least healthcare services to the remotest place of India, and that will be, I think, very, very affordable and accessible to India.
Very well put. Thank you.
We have space for one or two questions. The gentleman at Mr. Dr. Rajiv. Yes, Dr. Rajiv first, and then the gentleman at the back. Request all of our delegates to keep the questions to the point, as we are already slightly over time, but of course, can we please get the microphone there? No?
Yeah, thank you. In this discussion, this is really very gratifying to understand that private sector and the government sector are independently doing a lot of things in this area. What gives me a worry is what is the substantive plan to integrate the entire landscape of technology to ensure that from the patient perspective, he gets a true continuity of care. His records, including diagnosis, investigations, and outcomes over a lifespan of time is available from birth till death. What is the real substantive effort on the ground?
Yeah.
Thank you, sir. Very relevant question. The government has already taken the initiative by bringing the Ayushman Bharat Digital Mission with respect to this. So first answer to your question is to standardize and adopt global standards across the healthcare industry. That's a one piece. Second, I would request representing ABDM in the past was to adopt the ABDM, be the part of this mission. This is going to integrate the healthcare across the nation, wherein you have integrated services, be it laboratory, pharmacy, hospital, nursing home, telemedicine, everything. So this is what the short answer I would be giving to your question.
Short answer, very good.
Can I just add to this? So this also would require all the IT vendors to comply to that. The government can come up with a policy, but until the solutions are able to meet that, it will not do any good. So I think it's a much wider requirement to have everybody adopt to those policies.
Yeah, I want to give one important information to you. Have you heard about Abha ID? Okay, it means that each citizen has single ID. Means if you go to Apollo or any other hospitals, you can use that ID. Or if you come to the AIMS also, you have to use that ID. So in same ID means single medical records. So when you assess this one, you can assess in Ava ID. And this Ava ID, it can be integrated in your, this is another digital, what it is. The government of India has another apps which you can download it and you can put it in your mobile. No. E-Sanjeevani is a software for the virtual consultations. It is developed by.
You have to say something. Okay.
I have two questions. Number one, we have digitized all the things what we are talking about, our reports, our images, everything. Still, we are not doing in a tertiary care at least the paperless OTs. The paperless OTs are still missing because I don't know, because that will change not just the OT scenario, that will also have the right information to the doctor when he's doing a surgery or something. Second is then still I was discussing with somebody that we still use films and papers to give the MRI reports, CT reports. We don't have any system in India where we can see that reports are on a digital this thing for the patient. Thank you.
First question, it was the paperless OTs. It is there. In AIMS, we have already started there. You must have heard about the NCI Jhajjar, National Cancer Institute. We have a second campus, outreach campus in near to the Haryana, near to the Gurugram. It is around 300 acres of land. and already the 60 acres of land is operational. This is the only the largest cancer hospital in the country, 700 beds with state-of-art technology, inaugurated by Honorable Prime Minister PM Modi around 3 years back. This OT is totally a paperless. And what you are talking about, the filmless. Right now, filmless is not a big means new technology. People are using different kind of packs. Even the small hospitals, I can tell you can use open packs free of cost. You can download it and get some technical helps, and you can use it. And about 5 terabyte data, it can be